behalf of the House Ear Institute, I wanted to welcome Michael Teixido. Very excited to hear his grand round talks on migraine and Meniere's disease. Dr. Teixido is a neurologist based in Delaware. He's very active in our national societies, doing a lot of research. He's got a YouTube channel with millions of views on otology, neurotology topics, and he is the director of a fellowship there. Thank you for taking the time to talk to us.
Oh, absolutely. This is my pleasure to speak. I'm going to share my screen and find my slides here. There it is. Great. Well, thank you, Robin, for the invitation. And this is a topic that I think has been making the rounds. And once you hear about it, it starts to be more and more compelling. It has a way of getting into your thinking, especially in otology. We wanted to talk about this migraine and Meniere's disease and the relationship, and I definitely am going to do that. But I thought I would broaden the talk to talk, if I'm going to present a pathophysiologic model of migraine, I thought I'd run through the model and talk about where vestibular symptoms can be generated in that migraine world that our patients carry with them into our clinics. So, get my controls. So we're gonna, I don't think I need to review vestibular physiology in any detail with this crowd, but we are going to review the currently accepted pathophysiologic model of migraine so that we can examine more closely how migraine mechanisms can create vestibular symptoms in the cortex of the brain, in the brainstem nuclei, and other deep brain centers, and even in the inner ear, which is a topic that has been of significant discussion, even in our neurotology listserv recently. So none of us are going to achieve a feat of balance like this, but there is activity in the balance system that is no less impressive, that goes on in the background at all times. If you would just, all we have to do is remember our bilateral vestibular loss patients who tell us that they cannot even read in bed because when their saccule is not making compensatory eye movements for the bouncing in bed caused by the ejection of blood out of the aortic root, the image of the print on the page slips across the fovea and our visual image breaks down. So they have to actually brace their head against the bars of the bed to read. This is just testimony to the fact that when something works this well, we are very, very sensitive to its dysfunction, even subtle levels of dysfunction. So as we know, balance is actually an integration of visual and somatosensory and vestibular inputs. And so everyone says, oh, this has 3 parts. It actually has 4 parts because there is an integration of those inputs that is essential for this to function well. The vestibular labyrinth has 5 organs in each inner ear, 2 otolith organs, 2 which are linear accelerometers, of course, and 3 angular accelerometers. And it's important to note that the otolith organs came first and that the semicircular canals in evolution came later. And they came later because they needed to solve a problem. And then hearing came after that. Hearing was just an extension of the transduction mechanism, a mechanical to electrical, to high frequencies, much higher frequencies than sensed by balance. So as you know, the semicircular canals are primarily wired to the eye extraocular muscles to maintain the vestibulo-ocular reflex. And this way, when our head is moving, we can maintain an image on the fovea and function. with clear vision. But otoliths, which came first, those have some connections to the extraocular muscles, but their primary connections are to our somatic muscle fibers. So when we lean forward, in this case, our dorsal musculature is contracted to prevent us from falling. And they help us to stabilize our head by controlling muscle tone. So we all know that, but let's talk a little bit more in detail about migraine, which is a very common genetic disease. And there are 3 primary sites of symptom generation. When we think about migraine, and certainly what I was taught was that this is a problem of the blood vessels in the central nervous system. That's what I was taught in medical school. And that even if you're not taught that, it is the most sticky idea because we always think about vasoconstriction and dilation of these vessels. But we know now that a lot of symptoms come from the cortex of the brain, and still other symptoms come from other deep brain centers. When what we really think is going on in migraine is that all of the blood vessels in the head are innervated by the trigeminal nerve, and specifically unmyelinated C fibers, which are loaded with inflammatory neuropeptides like substance P, VIP, neuropeptide Y, but most notably CGRP, calcitonin gene related peptide, which is a potent vasodilator. These are the agents which, like a venom, sensitize these blood vessels and cause them to hurt when they pulsate. They are, if you want to ask someone what meningitis feels like, ask someone who has migraine. They have chemical meningitis. As otolaryngologists, we are aware that these same fibers innervate the nasal and sinus mucosa, causing congestion and pressure. And our specialty was rocked about 20 years ago by the sinus headache and migraine study, which showed that only 3 out of 100 individuals with sinus headache actually has rhinosinusitis. The rest have headaches in V2 in the region of the maxilla and the sinuses. And there's more interest now in the innervation of the inner ear and whether or not these kinds of changes can really affect the inner ear. And we're going to look a little bit more into that today. So when we think about vascular changes with a cerebral blood flow studies, really do document big vascular changes in migraine with a period of oligemia, which was always thought to correspond to the aura symptoms of migraine, and the hyperemia, which was thought to correspond to the headache phase of migraine. But actually the timing doesn't work out. The headache begins hours before vasodilation occurs, and the headache ends hours before the vasodilation ends. So the vasodilation and constriction is really not the primary event in migraine. It is this release of inflammatory mediators, the chemical spill, if you will. And that's the reason that patients with migraine who treat it early do better. And if it's late, it's hard to treat a chemical spill late. You know, I tell patients that trying to treat a migraine hours after it started is like throwing a roll of paper towels off the Exxon Valdez after it has already spilled everything. So where does the pain go? Well, we feel it intracranially, but it radiates because of referred innervation patterns externally. And if in live surgery experiments, if you stimulate the intracranial vessels, the rest of the brain is non-sensate, you get radiation to the periphery in these characteristic patterns. In the upper right, the orbitotemporal parietal area, that is where the hand goes during a migraine episode. And in the lower left, this is where a lot of our patients, as patients with Meniere's disease, say, yeah, I feel pressure. And they put their hand right down behind their ear and in the back of their neck. Well, we also get auras, and there's a lot of activity going on, not just in the vessels, but in the cortex. And Carl Lashley was a physiatrist in Boston in the 1940s, and he famously drew his own scintillating scotoma as it expanded and hypothesized that there must be an electrical wave of disturbance traveling between 3 and 5 millimeters per minute across the visual cortex. And that was a very cogent observation. He, across town, Aristides Leal was a graduate student in the laboratory of Halliwell Davis, who is considered the godfather of auditory physiology. He was working on a seizure model and demonstrated this progression of excitation followed by inhibition. He showed this to his mentor, who told him it was an artifact and that he should forget about it, but he published it anyway. And decades later, his spreading depression was recognized as the phenomena which explains cortical aura phenomena. So, and in the era of functional imaging, we can very clearly demonstrate this wave of excitation followed by inhibition, starting in the visual cortex. Now, in addition to this, we have parasympathetic outflow. The superior salivatory nucleus is almost always activated in a migraine episode. And this wouldn't really bear mentioning, except as otolaryngologists, it is really important because we get lacrimation, rhinorrhea, nasal congestion, generalized soft tissue swelling, as well as wide-ranging systemic effects because of the body-wide parasympathetic connections. And you can even tell a difference in heart rate and blood pressure and fundamental function of the vascular system and GI system in migraineurs during attacks and when they're not in attacks, and even when they're in between attacks. Now, let's talk about vestibular symptoms. Now, when we talked, this is a functional MRI of a patient having a visual aura from an exercise-induced migraine. This guy got off the basketball court and into the scanner, and this is 18 minutes of visual cortex activity. And we always think about auras as visual, but they can happen in any area of the cortex. So some people, unfortunately, there's a characteristic hereditary migraine pattern of hemiplegic migraine, where there's an aura down the motor strip. So these patients get a hemiplegia as the precursor to their headache. But you get aphasia, and certainly dizziness is a possibility. The question is, what kind of dizziness and where is the vestibular cortex? That's been elusive for a long time. The vestibular projections through the cortex are so diverse that it is referred to as something as the vestibular cortical network. And you can see how broad the connections are when saccadic eye movements are evoked. But on the left, you can, with canal stimulation, although there's diffuse stimulation, there's one particular area called the parietal opercular area, OP2, that is now generally considered the primary vestibular cortex. This is the area that, despite the diffuse activation, always seems to light up with canal stimulation. So if you get aura, spreading depression, spreading across the cortex in this area, you can have spinning vertigo. If you have aura spreading over other areas of the cortex, you can have other vestibular distortions, that can be very difficult to describe for a patient to describe. Now, in addition, we have problems in the brainstem nuclei. In the era of functional imaging, we can predict with 100% accuracy the site of a migraine episode because of increased activity in the dorsolateral pons, which is the site of the trigeminal nucleus. But that is not the only brainstem nucleus that is involved in a migraine episode. Almost every patient has a their own characteristic pattern of brainstem activation. And if the vestibular nuclei are involved, then all vestibular input from even a normally functioning labyrinth will be distorted. And that can cause a mismatch between the two ears, causing disequilibrium, head motion intolerance, visual motion intolerance, and frank vertigo. Now, these patients will often tell you when they've had chronic symptoms that they have taken typical peripheral vestibular suppressants like meclizine and diphenhydramine. They have, this is a tell that they do not have symptoms actually coming from the periphery. These are anticholinergic agents that act in the labyrinth, which have cholinergic afferents, in particular the semicircular canals, and less so the otolith organs. Now, as I mentioned, the otoliths came first, and not only could we balance with an otolith organ, but you could hear with an otolith organ. So early animals could hear up to 1500 hertz using the otolith organ, and even mammalian type 1 hair cells that are near the streola still phase lock up to 1500 hertz. But the primary issue is that there was a problem with the otolith organs and that there was no ability to distinguish tilt from translation. In order to distinguish tilt from translation, we needed the input of the semicircular canals. And then the semicircular canal and otolith input get combined and processed in the vestibular nuclei and in a feedback loop between the vestibular nuclei and the cerebellar vermis. This feedback loop is a GABAergic loop. This illustration shows the nodulus of the vermis where this happens, or where this feedback happens. And when we look at the patients with vestibular migraine, we know that they actually have the same perceptual thresholds for tilt and for rotation. So their otolith organs are not any more sensitive than yours or mine, and their semicircular canals are not any more sensitive. But when we give a stimulus that requires a low frequency combination of these two inputs called dynamic roll tilt, this is really difficult work to do, then the vestibular migraine patients have an extraordinary sensitivity. Now, we call it a sensitivity. What we're really showing is that they can tell that if something is wrong. And because they can tell something is wrong, they know they're moving at these low frequencies. And this something that is wrong is a faulty combination of the canal and otolith inputs. And it is and some dysfunction in this feedback loop is really the best explanation for the motion intolerance and the rocking dizziness, which our patients sometimes tell us about. Remember that rocking is not a symptom that can happen in the labyrinth. There's a very, very rare lesion, a pulsatile compression of a broad dehiscence or something that could cause an oscillopsia. But most rocking dizziness is central and probably originates in this feedback. And it explains why those symptoms respond uniquely to clonazepam and lorazepam, which are GABAergic rather than cholinergic. Now, there are fibers which ascend to the thalamus where we become aware of motion and of our position in space. And we know that there are converging projections from the vestibular nuclei and the dura sensitive neurons, trigeminal fibers that go to the thalamus. And it's quite possible that there is some convergence amplification that occurs in the thalamus that causes us to have symptoms that may generate there. Now, this may be very, very similar to the photophobia mechanism described by Remy Bernstein, in which there is a convergence of retinal, light-sensitive retinal afferents and dura-sensitive fibers in the thalamus, so that when we apply bright light, there's increased firing of the pain fibers. And this explains why light hurts in migraine patients, and motion can cause pain in head motion, can cause pain in some migraine patients. When we have problems, distortions of input to the thalamus, we can get distortions in our perception of self in space, things like Alice in Wonderland syndrome, shown here in the Arthur Rackham famous illustrations of that story. And the patients sometimes tell us that they're displaced in space. They say, like, I feel like I'm here talking to you. I'm here talking to you, but I feel like I'm back here speaking, looking at the world from a third position. It may be that some of the patients who to which we are attributing the diagnosis PPPD may actually have some dysfunction in the thalamus. And my own opinion is that PPPD is largely overdiagnosed. It exists, and it's kind of a feature of symptoms that results from focusing on the vestibular sensorium, but it is very similar to the very symptoms that could be generated in the thalamus. Obviously, the big question always has been, is it central or peripheral when we talk to a vestibular patient? And the reality seems to be that it may be both. Let's consider that patients with migraine, when we stimulate the supraorbital nerve electrically, we can induce ipsilateral nystagmus in them. Now, when we do this, we know it's ipsilateral. It has a mean latency of about 25 seconds and lasts for about 120 seconds. This corresponds roughly to what we would expect from a neuropeptide release and then sequestration. It is visually suppressed, and the slow phase of the nystagmus is linear rather than logarithmic, proving its peripheral origin. How about the inner ear? Is it innervated by these vessels? Well, it seems to be. And so how do we manipulate that system? Well, these C fibers, which are present all over the body, have on them a family of receptors called vanilloid receptors. These are receptors that are sensitive to thermal change and mechanical distortion and to acid, and also to capsaicin. It is when we eat hot peppers, it is the stimulation of the vanilloid receptors in our tongue that causes the release of these very peptides, and that causes our mouth to burn. So when we give capsaicin, we have big changes in cochlear blood flow seen in the upper left. We also see a threshold elevation of about 10 decibels across all frequencies. This is not a low frequency threshold elevation. This is across all frequencies, and it's reversible. This threshold elevation is not caused by any change in endocochlear potential. but it seems to be related to a blunting of the tuning curve, but in a way that is not typical. Usually when the tuning curve is blunted, the specificity of that inner hair cell aiming, or that mechanical focus, gets broadened, but this retains its rather sharp peak, just less extreme. Now, Zoltan Vas at Oregon Health Sciences University was in Nuttall's lab, and he showed that you could stimulate V1 and cause rather profound changes with transmural extravasation of proteins in the cochlear medullary artery. Now, he didn't look at the vestibular labyrinth, but it has the same innervation. And you can see how different the stimulated versus the control animals were. So it begs the question, could this mechanism of inflammatory mediator release a cascade of physiologic changes that causes blood vessel changes and diffusion of inflammatory mediators, which have their own effects on the hearing and on the vestibular epithelium? And could it cause endolymphatic hydrops in individuals? Or maybe it just goes back to normal. Maybe there are episodes the ear goes through and goes back to normal, and in other individuals, the ear gets injured. Robert Balow, he looked at patients who had a family history of Meniere's disease and migraine together. And he looked at these individuals and saw that in the patients who had both Meniere's disease and migraine, there was an earlier onset of the symptoms. Those are the black bars, and this is age. And that once hearing loss occurs, there wasn't very much progression. That is to say, once the presence of migraine did not seem to affect the progression of hearing loss after the hearing loss actually occurred. When you look at the Meniere's patients compared to the patients who have Meniere's disease and migraine, there is a much higher female to male prevalence in the Meniere's disease migraine group, a much higher family history of vertigo, and a much higher incidence of bilateral hearing loss in those individuals. It makes us think that Meniere's disease may be a complication of migraine in some individuals. We know that hydropic ears have impaired cochlear blood flow, but what fits into this model is that hydropic ears have about 70% fewer C fibers. And we think that this is important when even experimental hydrops can induce these changes. You know, Meniere's disease burns out because even though the ear might continue to get battered by migraine storms, it has a much more sparse population of C fibers to affect injury on the ear, in much the same way that you get adapted to spicy food, and it takes more and more capsaicin to get you that satisfying glow of heat. When we look at the epidemiology, we know the prevalence of migraine in International Headache Society criteria. Migraine is 13%. And believe me, IHS migraine is so obvious that you don't need a doctor to diagnose it. You can go to the mall and ask the teenagers who are running the piercing pagoda, you know, if you have migraine, and they'll know, because this is such an obvious sort of criteria. But a lot of patients with migraine don't meet the criteria. More than a quarter of patients with migraine will get dizziness in their lifetime, vertigo. And so it's very high incidence of vestibular migraine. We know that up to 56% of patients with Meniere's disease have this obvious migraine, and that there's a lifetime prevalence of of migraine in Meniere's disease of 43% in women and 19% in men. Really, when we're in the clinic, we should be seeing 15 or 20 vestibular migraine patients for every single Meniere's patient we see. It also bears mentioning that Meniere's attacks are accompanied by at least one classical migraine symptom like headache or photophobia or aura symptoms in about 45% of patients all the time, and only sometimes in about 11% of patients. So there are some rather notable characteristics and similarities between Meniere's disease and migraine, mostly that both are the types of episodes which can be triggered. We tell our Meniere's patients to avoid salt, and well, in migraine, dehydration is one of the primary triggers. So eating salt just causes dehydration. And food triggers, you know, caffeine, chocolate, and alcohol in Meniere's disease can be helpful. But those are the three, caffeine, chocolate, and red wine in particular, are the three horsemen of the migraine apocalypse. Of all of the food triggers which have been described, they are food triggers, not because you're allergic to them, but because they resemble central stimulatory neurotransmitters, or they're complex chemical byproducts of fermentation or dehydration. Meniere's disease and migraine are famously aggravated by stress and respond to stress management. They are both famously aggravated by allergy, and both respond to allergy management. And there's a direct correlation. Jennifer can tell you all about allergy and Meniere's disease. There is also, Meniere's disease is an excitatory followed by an inhibitory nystagmus. That's the excitatory phase is rarely witnessed, but it begs the question if spreading depression might be possible in the vestibular epithelium. We also know that Meniere's disease burns out, and migraine tends to burn out as well. The headaches that people experience in youth tend to become less debilitating and intense and simmer down to a generalized pressure. In fact, a lot of our patients tell us that they no longer have headache when we have a vestibular migraine patient. And then on further questioning, you find out that they have pressure that's there almost all the time. They just don't consider it a headache compared to what they used to suffer. So that, along with the epidemiology, which we mentioned, and the lifetime prevalence of Meniere's disease is very notable. 85% of patients with bilateral Meniere's disease have IHS migraine. So it's taken us a long time to come back around to something that Prosper Meniere himself pointed out 150 years ago. If it is not incontestable that individuals who are prey to vertigo, syncope, and vomiting have at the same time head noises and rapidly become deaf, is it not less certain that cerebral states called migraine give place in the end to similar attacks, and that the deafness which arises in these circumstances would seem to us inevitably to be related to a disease of the same nature? So it's not surprising that some of the patients we see will meet the criteria for vestibular migraine, and others will meet the criteria very specifically for Meniere's disease, but a lot of people are going to fall in between the two. When we do VNG testing, we may see that there is a caloric weakness in 15 to 35% of patients with vestibular migraine. Well, these patients have migraine headache, and there's something that is actually injuring the labyrinth. We see abnormal saccades, and we usually expect to see in patients 65 and older, but in a 35-year-old young woman who comes to the clinic. And also very often you don't get 4 caloric irrigations because the patient was so sensitive to the stimulation, they would not allow further calorics. And also, instead of recovering and driving themselves home, the patient had a long incapacitating attack provoked by the stimulation of the VNG, which caused them to which was a memorable event and swears them off of ever having vestibular testing again. Believe it or not, there's even a coincidence of migraine and BPPV. If you can get a vestibular nerve weakness from migraine, well, maybe you can get injury of the end organ, the utricle, and get more BPPV. Well, it turns out that migraine is 3 times more frequent in idiopathic BPPV than in BPPV that's secondary to head trauma or surgery. The migraine is 2 times more prevalent in patients with BPPV than in age and sex-matched controls. And in general, if you have migraine, you're 7.5 times more likely to get BPPV. When you look at BPPV, there's a definite female to male prevalence, and about 33% of episodes are preceded by headache immediately before the BPPV occurs. When you look at cases of recurrent BPPV, there is a huge 3.2 to 1 prevalence of female to male patients, especially in the menopausal years. So we think that hormonal fluctuations really may increase the tendency to develop BPPV, probably because of an aggravation of migraine activity. This is a patient who's from my YouTube channel. I have many patients, 15 or 20 with recurrent BPPV. They didn't have significant other ear symptoms or even headache. She had ear fullness in one ear. And she had been fixed with canalith repositioning 7 times in the preceding 4 years by a competent physical therapist. And she was treated with preventive therapy, nortriptyline, low dose nortriptyline at 20 milligrams, and her ear fullness went away and her recurrent BPPV stopped. I looked at 500 patients in my clinic, and with 236 vestibular migraine patients, 212 BPPV patients, and 169 migraine patients. And you can see there's a distinct overlap of these problems. And of the vestibular migraine patients, 22% of them have BPPV. And of generalized BPPV patients, about almost 30% of them had migraine. These are really high compared to the population prevalence of BPPV and migraine in the general population. So there are other otologic presentations of migraine as well. And I'm only mentioning facial pressure because of the migraine and otolaryngology study that rocked the world. The vestibular, the Rhinologic Society doesn't want to talk about it. If you submit a paper with the word migraine, it will not be accepted. But in otology, we have lots of patients with aural pressure, and that can be a manifestation of migraine activity in the ear. We have patients with hyperacusis because of possible distortions and hyperactivity in the vestibular nuclei. Patients who have recurrent vestibulopathy of unknown origin may not all have reactivation of herpes simplex virus from chickenpox. They actually may have recurrent migraine opathy of the vestibular nerve that can cause enhancement on MRI. And then responds. In fact, Antoni Mikulik did a nice study showing that 77% of patients with recurrent vestibulopathy of unknown origin responded to a 3-part treatment regimen of either topiramate or nortriptyline, depending on which one they tolerated, and caffeine cessation alone. And of course, recurrent idiopathic BPPV, otalgia, and maybe even sudden sensorineural hearing loss. And there's been some evidence recently that if you take patients and you randomize them and you treat patients with dexamethasone perfusions, but then 1/2 of the patients get empiric migraine management with preventive agents, that 6 months later, there's a 10 decibel better outcome in the patient who got the empiric migraine treatment. So in summary, symptoms of dizziness can be created by migraine mechanisms in the cerebral cortex, in the brainstem nuclei, in the interaction between the vestibular nuclei and the cerebellar vermis, in the thalamus, and also in the inner ear. So, so these mechanisms can create a really challenging combinations of central and peripheral vestibular symptoms. And in some susceptible individuals, it seems that Meniere's disease may develop as a complication of migraine. And if both are present, we should treat both. It's often beneficial and necessary. I see as much Meniere's disease as anyone, and I treat a lot of migraine, and I only get to where I do a gentamicin perfusion 2 or 3 times a year. I think that the migraine management is effective at calming down Meniere's activity and preserving function. Familiarity with migraine and its treatment is now emerging as a necessary part of otologic medicine. Our neurology colleagues are in a period of transition, and they don't know how to treat these peripheral problems, even if they are aggravated by migraine mechanisms. And they are often, far too often, married to the ICHD, the International Classification of Headache Disorders, classifications of migraine and vestibular migraine, and they inappropriately use the existing criteria as exclusion criteria for treatment. So the patients come back and they say, he doesn't think I have migraine. He doesn't think I have vestibular migraine. He doesn't even think I have migraine. And, we just have to remind ourselves that those criteria exist for study, so that epidemiologic and so that drug efficacy studies can be competently performed, and we can advance our science and knowledge and create new distinctions. And so any classification is a work in progress, and we should not be guilty of using them as exclusion criteria ourselves.